And Bernardo is going to talk about the challenge of calcium in lower limb revascularization.
Thanks. I think Miguel just showed you that calcium is bad. So then we talk. So quickly, no conflict of interest. So, prepared for this talk, I just went to ChatGPT and said, calcification. Okay, give me a talk. Look at this, everything, right? So I think Miguel put it very, very well, right? Basically, age, diabetes, chronic kidney disease, smoking. It's a patient that we see daily on our PAD clinics, and the ones that are like end-stage renal disease are the ones I worry about all the time because, like Miguel showed, most probably, even if I can get a wire across, do CSI, do something, they all come back, right? So when I see calcification, what's my approach? What do I do, right? So the first thing I always ask myself is, right, where's the location of the calcium? I know Miguel showed you that you can look at the X-ray and say, oh, there's calcification there, but the truth of the matter is it doesn't tell you where it is, right? Is it medial, which I don't worry about, or is it intimal, right? And if it's intimal, the next question I ask right away is it concentric or just a nodule or something less than 270? So if it's concentric circumferential, I worry about it, right? And then typically, if I see that, I say, okay, I need lesion modification. And I think everybody agrees that when you see this, the only way you can have an adequate lumen at the end of the day would be to do debulking or atherectomy. Then the question all the time is, this is when we were starting this shockwave fad before, is I said, I need to see IVUS because if it's less than 270 or 180, I don't think I need any debulking. Balloon would work, right? And true enough, that's true. But the key thing is you have to use OCT or IVUS, right? So I would say heavily calcified vessel is our enemy, right? And you can see on angiography, very resistant to dilatation, recall, dissection, embolization. Then it doesn't respond well to just balloon angioplasty. Typically, you have a incidence of doing stenting, right? Then, of course, one thing that we forget all the time, if heavily calcified, advancing devices to the lesion is very, very difficult because you lose the compliance of the vessels. So current therapy, I think, as of today, it's basically the use of lesion modification. And I would say it's your comfort zone, right? If you want to use CSI, you want to use Shockwave, or you want to use Boston, or you want to use the Hawk one, it all depends on your comfort zone. So how does it affect my daily practice? So let's say I got a patient in, do an angio, and see very heavily calcified. So typically, it's a challenge, right? Antegrade is most probably going to be difficult to do, so I have a low threshold to do retrograde canalization or just do a subintimal approach. Then, of course, lesion modification we talk about. Then, of course, definite therapy is still the same for me, DCB and stenting. But if you look at the data, it's going to be a high use of stenting just because of the recoil that you see from calcification. So so I look at this, this is like a table that I use all the time I give to my fellows. It's what I call lesion specific, right? That means to say, if it's calcified, these are the options that I have. Really, if it's heavily calcified, rather than 270, I have only two options really, either rotational orbital atherectomy or intravascular lithotripsy. Laser works, right? And I think Eric showed a while ago that you can use this in calcified lesion, and we do this. If it's a short segment, what I typically do is use it with contrast, right? And it's very simple. What I do is use a laser cutter, put a TUI at the back end, then instead of using a syringe, just inject the contrast into the side port of the TUI, and then you deliver the contrast at the tip of the laser catheter. It works if you have a short segment. If long segment, it's very, very frustrating. Okay. So basically, we're left with orbital atherectomy or intravascular lithotripsy. Then here comes the lesion, right? If you're a high-grade lesion or even a CTO, as long as you have the wire across the lesion, you should be able to use rotational atherectomy. But if not, you need a pilot channel for lithotripsy. Okay, so that's the only drawback of using lithotripsy in this scenario, right? So why debulk? I think we talked about this a while ago. Luminal gain, lesion modification, then hopefully improve long-term patency. But we also know very well that at the end of the day, right, we improve acute outcome, but we don't have data to show that if I improve the acute outcome, I have better long-term patency. Okay, so I think we talked about this. So very good sample here, right? A pop that's totally occluded. Was referred to us after failure. The patient has rotarified symptoms. So I tried to go retrograde away, couldn't cross it. I used this device. I think, I don't remember, it's an old device, and was able to cross it, right? And then I IVUS. Like I said, calcified lesion, IVUS all the time. And you can see that it's 360 degrees all the way around. And so I decided to go with treatment option, like I said, right? You can do POBA if you want to, but most probably results are going to be good. You can do shockwave, but it won't cross a CTO. So basically, we're left with basic orbital, rotation, or mechanical atherectomy. And I decided to go with the orbital atherectomy. I did 1.5 run and 2.0 burr and ran it for a total about 1 minute 10 seconds, and then you get very, very good result. So what we'll do, Eric, I have a filter there. So this is what we're looking for, right? So from a baseline, post-debulking, and you look for the cracks. The same thing with shockwave IVL. That's what I do all the time. IVUS, shockwave, post-shockwave, do an IVL. If you see all the cracks, then you know very well that you get a nice angiographic result. So with this, we got very, very nice result. Okay. So quickly, the rules that I follow, same thing. I use embolic protection, I would say 99% of the time, if I can use it. Now, is there good science to what I'm doing or what we're doing? Really, none, right? And I always question myself, we're looking for this single-digit restenosis rate, but like I said, maybe a single-digit restenosis rate like in the coronary data is not a reality for us. So quickly here, claudicant, common femoral, SFA, osteal disease, smoker for years, right? If you think about it, options, send to the surgeon, do an enterectomy, and be done with it, and they would get us very, very good clinical result. Or you can do intervention, right? I wrote down there, I perform with some trepidation. I would think that when we do any of this procedure, especially what we say off the books, we see guideline directed, and of course, always your bias, your expertise, and of course, the patient's option, right? I always give the patient basically the option of getting surgically done, but I opted to go for endovascular. So the question is, what's wrong doing it endovascularly, right? So OBLs can do this case, right? Most probably it's local anesthesia and same-day discharge. So what's holding us back, right, for common femoral artery disease? Say, is that CTO? No, it's not. Is there a need to debug? No, it's not. Unable to stent? Not really, right? It's basically a severe calcification. We're worried about, are we going to get an acceptable result with our intervention? So we did this, easy to cross, did a shockwave, and I think they've shown the mechanism of a shockwave, and very nice result, right? And I have the IVUS for this, show that we really got a very, very nice result with shockwave IVL, and then I did DCB as definitive therapy. So this is data from the third DISRUPT-3 trial, right? So basically, in conclusion, right, so when we have patients with this disease, right, if you decide to go PI, we know very well the definitive therapy is basically stenting or drug-coated balloon. I think balloon angioplasty is of the question. But if heavily calcified lesion, I think you have to form lesion modification, or atherectomy or IVL, or atherectomy and debulking. And hopefully, remember, debulking, atherectomy is not a standalone treatment option, right? Then hopefully when we do this, we'll give them a good 2-year result with DES stenting as well as DCB. So to end, we do more procedure, we have more devices, and the problem is we get more complications. And I think important is you have understanding, so you have less complications. So in summary, calcification 270 to 360, you need to modify the lesion. Lesion-specific approach is very, very important. At the end of the day, you have to be sort of the master of the device that you use so you can avoid complications. Thank you.